Before we take a look at IV insertion, we have to spend a little bit of time talking about both IV equipment and IV insertion sites. These are the learning objectives that will be covered within this video. We've talked about IV solutions, but let's start now by taking a little bit of a closer look at the IV bags themselves. You'll notice that most IV bags have two different ports. One is the administration port, where the IV tubing connects to the bag, and the other is the medication port, where medications can be added to the bag of IV solution if needed or desired. There are a variety of types of IV bags and bottles, so the ports may look different or be located in different places depending on the type of bag you use. For example, some plastic bottles simply have one rubber stopper with two ports in it. Let's work our way down and start by talking about the different parts of IV tubing. At one end of the IV tubing is the spike. This is the part that will be inserted into the administration port on the bag of IV solution, after the caps have been removed from both. Below the spike is the drip chamber. Some drip chambers of IV tubing sets have vents in them that can be opened and others do not. A vent helps to allow air into the bottle of IV solution so that the fluid can flow out. You typically only need a vent if you are using a rigid IV bottle, such as a glass bottle. A soft bag or plastic bottle will just collapse as the fluid flows out, so a vent is not needed. There are two different types of tubing you may encounter as a midwife: macro drip tubing and micro drip. Macro and micro refer to the size of the drip that is created by the drip chamber of the tubing. Macro drip tubing is generally 10 to 20 drips, abbreviated as GTT, per milliliter, meaning that if the drip factor of the tubing is 10, then 10 drips of fluid are needed to equal 1 milliliter of solution. Macro drip tubing is what you will most likely use and encounter as a midwife. Fluids can be given quickly through it if needed. Micro drip tubing is generally 50 to 60 drips per ml, meaning that if our tubing drip factor is 60, it will take 60 drips within the drip chamber to equal 1 milliliter. Quite a significant difference compared to macro drip tubing. Micro drip tubing is used in situations where greater control is needed over the IV fluid drip rate, such as with medication administration or solutions that have to be administered carefully. This tubing should not be used if you want to give fluid fast. It is typically only used for giving solutions at a rate of less than 100 milliliters per hour. Back to our IV tubing. Following the tubing down, we have the roller clamp. This is what is used to adjust the IV fluid drip rate within the drip chamber. Below this is an injection port. Most IV tubing sets have at least one of these, but some do not have any. An injection port is a place in the tubing where you can administer a medication directly into the tubing and to the patient. For example, in the hospital, an IV pain medication would be given through an injection port of the tubing, so that it would flow directly to the patient. If it was mixed in the whole bag of IV solution, then it would be diluted and only given at a slow rate. Many IV tubing sets have a slide clamp in addition to the roller clamp. A slide clamp is what is inserted into an IV pump to control the rate of fluid, such as in a hospital setting. Finally, at the end of the tubing we have the threaded lock, which is also capped. Once the IV catheter is in place, the cap is removed, and the threaded lock can be twisted on and attached to the cannula. Now let's take a look at IV cannulas. There are many different types and varieties of IV cannulas, but the basics remain the same. There is a needle, and covering the needle is a plastic, flexible cannula, also known as a catheter. Notice that the needle sticks out beyond the length of the cannula. This is so that you can insert it through the skin and into the vein. Then you have the hub of the cannula, a flashback chamber, and, depending on the style of cannula you work with, you may have a cap or plug at the end. Some cannulas have a port on top, which can be used to flush it or to give a medication directly into the bloodstream. Others do not have this, and the injection port on the IV tubing would be used. All IV cannulas are basically two parts, which separate and come apart. The cannula and the hub slide off of the needle once you have it in place and stay in the vein. The needle and the back part are thrown away. Some IV cannulas have a built-in safety system so that as soon as you withdraw the needle, you can press a button and the needle will retract back into the flashback chamber in the back part. Or they may be designed with something that slides up and over the tip of the needle once it is removed. These safety systems are helpful in preventing accidental needle sticks, but not all cannulas have them. If you use a cannula without a built-in safety system, you need to practice needle safety in order to avoid poking yourself or others. You should always try to discard of the needle in a sharps container as soon as possible. IV cannulas come in a variety of different sizes and lengths. The size of a cannula is referred to as its gauge, and the larger the gauge number, the smaller the size of the cannula. Most IV cannulas are universally color-coded, meaning that an 18-gauge cannula will always be green, and a 14-gauge will always be orange. 14 to 16-gauge IV cannulas are used for donating blood, or for trauma cases, such as in an emergency room, where things like fluid, blood, or blood products need to be infused quickly. They are very big, which allows for fluid and blood to flow quickly through them, but they also require a large vein and insertion is painful. 18 and 20-gauge IV cannulas are the ones you are most likely to see and use. Fluids and blood can be given through both of them, but an 18-gauge is more commonly used in obstetrics, as fluid and blood can be given faster than through a 20-gauge. A decent size vein is needed, and insertion is still painful, but less so than with a 14 to 16 gauge. If in your practice as a midwife you have a patient with small veins and have a hard time inserting an 18 gauge, a 20 gauge may be a good alternative option. 22 and 24 gauge IV cannulas are used more so with children and babies, or in people with small, fragile veins. Because they are considerably smaller, insertion is easier and they can be started in small veins. But because of their size, blood or blood products cannot be given through them, and fluids cannot be given at a fast rate. To look at the differences between them another way, the maximum rate fluid can flow through a 24-gauge IV cannula is 13 milliliters per minute, meaning it would take you 77 minutes to give 1 liter of solution, even if you were using macro-drip tubing and had the clamp open all the way. The maximum flow through an 18-gauge cannula is 103 milliliters per minute, meaning you could give a whole bag of solution in about 10 minutes. The maximum flow rate through a 14-gauge cannula is 270 milliliters per minute, meaning you could give a whole liter in 3.7 minutes. Okay, let's take a look now at IV insertion sites, starting by looking at the difference between veins and arteries. Arteries carry oxygenated blood away from the heart. They are generally located deeper within the body and are less numerous than veins, so the pressure within them is higher. Because of this, they have thick muscular walls. When you check a pulse on a patient, you are feeling the pulse of blood through an artery. Looking at this arm, we can see there's only one main artery in the body that carries blood down the upper arm, called the brachial artery. Just before the elbow, the artery splits into two branches. The radial branch runs along the thumb side of the arm. This is the artery typically used to check a woman's pulse on, near her wrist. The ulnar artery runs down the opposite side of the arm. Veins are what IVs are started on. They carry unoxygenated blood back to the heart, which is why IV cannulas are inserted in the same direction, following the flow of blood towards the heart. They are located more superficially within the body and are more numerous, so the pressure within them is lower than that within arteries. Their walls are thinner and contain valves to aid in the flow of blood back to the heart. The valves in veins are one-way valves that open as the heart pumps and pushes blood through them, and then close in between heartbeats to prevent the blood from flowing backward within the vein. Valves are important in the extremities, especially the legs, because of gravity. Blood would tend to pool and would have a hard time making it back up into the heart were it not for the function of valves. Finally, you cannot palpate a pulse from the flow of blood through a vein. Let's take a look at the most common veins IVs are started on. First, there are the metacarpal veins located on the back of the hand. They are easy to access, and it's nice as the IV cannula hub lies flat against the back of the hand. However, hand IVs may affect wrist mobility in the use of that hand by your patient. Insertion is more painful, and the site tends to become irritated and infected more easily. The cephalic vein is located on the radial side, the thumb side of the arm. It is the main vein that runs along the inner part of the arm, and then curves around to the side of the wrist right below the thumb. There is a vein that branches off the cephalic vein and runs around to the top of the arm, rejoining up with it near the wrist. This is called the accessory cephalic vein. Both are a great option for starting an IV on. They are large veins, and the mobility of the patient's arm and hand is generally not affected, unless it is started at the wrist. These veins may roll during insertion, so you should anchor them well, which we'll talk about in the next video. Insertion is generally said to be less painful than the metacarpal veins. The basilic vein runs along the ulnar aspect of the forearm and the arm. This vein is also a good straight vein to start an IV in, and typically mobility of that arm is not affected by it. The vein may roll during insertion, and insertion is said to be a little more painful. All in all, it's very similar to the cephalic veins. From my experience, the basilic veins are a little smaller and harder to start IVs on than the cephalic. Lastly, I want to talk about the antecubital veins. These are the veins most commonly used for blood draws. They are generally easy to see and palpate, and are a great option if you are in a hurry, such as in emergencies, or as a last resort on a patient that you simply can't get an IV started on. Mobility of that whole arm is generally very affected and restricted, so it is not ideal for a laboring woman or a new mother who needs to care for her baby. Also, these veins cross over top of the arteries, and risks are greater to puncture or damage an artery in the process. Now that we've talked about veins for IV insertion, let's look at a few rules for selecting an insertion site. First, pick a good vein. You want a vein that is straight and smooth, without any valves in the section of vein where the IV cannula will be placed. Valves present as a lump or bump within the vein, usually visible once the tourniquet is applied. It's hard to tell from just a picture, but this looks like it is probably a valve here, and perhaps there's one here too. Sometimes it is helpful to use your capped IV cannula as a guide to tell if the vein you are looking at is long and straight enough. We wouldn't want to start an IV here, because we would have this vein joining in, which means there's probably a valve there. We could start below that though, or above it, as long as we keep below this Y of intersecting veins. We could also come over here and start on the cephalic vein below the same intersection. Generally, starting an IV right at a Y or just above a valve is a good place and provides a good distance till the next valve. But we can see in this case we have a valve here just above the Y. So if we moved up, we'd want to start it above the valve. Or we could move over here and start it on the basilic vein, which looks smaller but straight as well. As you can see, there are generally quite a few options, which leads to this next rule. Start distal and move proximal. Let's say we attempt an IV start on our first try here, and we blow it because we accidentally punctured through both sides of the vein. Because of this vein being damaged now, we cannot start the IV below or distal to it here, here, or even here, because all these veins flow directly into the one we just blew. You wouldn't want to run extra fluid through it as it may leak out into the tissues and cause further damage. So with one blown IV start, we've eliminated 3 of our other potential IV sites as well. On the other hand, if we started with a distal site, like here, and we blew it, we could still start an IV here, here, or here, because they are above the area we blew, and the fluid we added wouldn't be flowing directly through it on its way to the heart and the rest of the body. As you are learning, it may be good to follow this rule because it provides more options for you or someone else to try again if you are not successful. Once you are competent and comfortable with the skill of inserting IVs, you may decide to move upward and use the cephalic or basilic vein more often than the metacarpal veins because of the added benefit of more patient comfort and mobility of that arm and hand. Another good rule is to ask the woman which is her dominant hand, and if possible, to start an IV on her non-dominant hand. It will be more comfortable for the patient and allow her full use of her dominant hand regardless of the IV insertion site. This becomes especially important when a woman is trying to hold and breastfeed her newborn. Avoid areas of flexion, basically joints. Try to stay away from the wrist and the elbow, as IVs placed over joints are likely to be more painful, become more irritated, and are more likely to be displaced or to infiltrate. The flow of the fluid through the IV is also more likely to be affected by movement if the cannula or tubing becomes pinched. The last rule is to avoid damaged veins or limbs. You want to try to avoid starting an IV at a site where there is bruising, scar tissue, or burns. Choose the other arm if you have a patient who has anything on one side that may affect the flow of fluid. For example, patients with a fracture or break, or for those who've had a radical mastectomy. This concludes this video covering IV equipment and insertion sites. In the next video, we will take a look at the actual IV insertion process.